Every year, scientific discoveries push the field of rheumatology forward in ways that shape both our understanding of disease and the way that we care for patients. At ACR Convergence 2024, Dr. Chris Ritchlin delivered a fascinating talk titled The Year in Preview, highlighting some of the most promising research that could transform rheumatology in the coming years. Today, he joins us to break down the key takeaways, what's next for precision medicine in rheumatoid arthritis, the role of TRBV9 cells in axial spondyloarthritis, how sex differences impact psoriatic arthritis, and the promise of urinary biomarkers in lupus nephritis. Dr. Chris Ritchlin is professor of rheumatology at the University of Rochester Medical Center. His basic science research focuses on understanding the mechanisms of bone resorption and new bone formation in psoriatic and rheumatoid arthritis. He's the principal investigator on several clinical trials testing numerous drugs for the treatment of these diseases. He directs the NIAMS Accelerated Medicine Partnership Autoimmune Inflammatory Mediated Psoriatic Disease Team, focused on understanding the events that underlie psoriasis and psoriatic arthritis using technologies such as single-cell RNA-seq and spatial transcriptomics. This discussion is really a glimpse into the future of rheumatology, with insights from one of the field's leading experts. Let's get started. Chris, welcome to the show.
Thank you. It's great to be here, John.
So you had this fantastic lecture at Convergence called The Year in Preview. And it basically talks about scientific discoveries that you thought would have a particularly, strong impact moving forward. And you chose a few abstracts. So we thought it'd be a great idea to sort of chat about some of those articles that you chose. And you could tell us a little bit about why those abstracts you thought are going to have a huge impact in the field of rheumatology going forward. The first one I'd like to talk about is about fibroblasts in RA and sort of the CRISPR deletion of genes in fibroblasts. But first, can you walk us through the role of fibroblasts in rheumatoid arthritis? What do we know about that?
Well, John, fibroblasts have been known to be part of the synovial lining for a very long time. It was really the work of Gary Firestein about 15, 20 years ago that showed that there are subsets of fibroblasts in the synovium that express oncogenes. And then with the advent of single-cell RNA-seq, largely through the AIM program, we were able to identify specific markers of different fibroblast subsets, those that are more likely to be pro-inflammatory, those that are more likely to release metalloproteinases and degrade the matrix. But it's now become even more exciting in that we now know that if you look at the fibroblasts in the knee, they're different than the fibroblasts in the wrist.
No kidding.
Yeah. So the ones in the wrist, first of all, you're more likely to have lymphocyte expansion in the wrist and an expansion of vascular endothelium compared to the knee where you're seeing more monocytes and you have often less of an inflammatory pauciimmune type of picture. And then they've gone and found that there is this molecule called hot air.
Wonderful name.
and hot air is responsible for directing whether or not you can increase barrier function and stromal buildup, if you will. And it's modulated in the wrist by long-coding mRNA, which blocks this molecule. And it turns out that it's lower in the wrist than the knee where there's no long-coding RNA, which is why it might be more of a fibrotic pauciarticular picture in the knee. Now, if that's not fascinating, I don't know what is, right? So we're getting all this new news. Now there's AMP 2.0, where we're engaged in looking at this in psoriatic arthritis and rheumatoid arthritis and comparing them and even delving deeper into these subsets with spatial transcriptomics. So really exciting.
That is super interesting. I always wondered, why rheumatoid arthritis affects certain joints and not others, and PSA, some other types of joints. Also, when thinking about vasculitis, right? Like a small vessel vasculitis doesn't affect all small vessels equally. It has a, predominance for the kidney, the lungs, And it's fascinating to think that the structure of the wrist or the knee are actually different, like the synovium is different. That is truly fascinating.
No, Jess, of course, I also have to mention your colleague, Peter Nigrovich's lab, has shown that T resident memory cells can also contribute to the likelihood of joints having recurrent arthritis, the same joints, and then spreading to others in a beautiful paper last year in Nature Review. So I think it's a combination of innate immune cells having memory and also our T resident memory cells that are driving that recurrence in the same
Wow.
joint.
Super interesting. So, about this paper, that this abstract that you chose, I think the authors wanted to sort of use CRISPR to try to better understand fibroblasts and their role in RA. Can you walk us through sort of what they did and what we learned from
Yeah,
that?
so as mentioned in AMP 1.0, the single cell RNA-seq identified a number of targets in fibroblasts that may be important at either driving or inhibiting inflammation. So what the Brenner lab has done in this particular abstract is say, okay, let's cut out those identified targets using CRISPR-Cas9, and then we'll cut those out in specific molecules out, and then we're going to stimulate these fibroblasts with cytokines and measure what effect taking out that particular molecule has either increasing the immune response of that fibroblast cell set or decreasing it. So what you can do with this now is create a map
Hmm.
of rheumatoid synovial fibroblasts. This is not taken from somewhere else, taken from the joint, as to what are the molecules that seem to be driving inflammation that we may not really fully understand, and those that are blocking it. And now to develop more precision based therapies that are directed toward these specific fibroblast subset molecules.
That's super interesting. And do we have any idea how our current therapies affect fibroblasts, like TNF inhibitors and methotrexate, things
Yeah,
like
so
that?
we have some data, but not in the detail that we need. And this kind of approach, I think, will help us to move forward in that direction. And also the idea that at some point where we're able to get even a little bit of synovium with a needle and then take that synovium and be able to deconstruct it in terms of the key mechanisms in
Wow.
that patient, I think, and we've already talked about it, depends on what joint you take it from, right? Whether it's the wrist or the knee or the ankle, you might get a different result. So I think we're just learning a lot right now that'll lead us into more specific therapies.
Super. So in the future, maybe, for this idea of personalized medicine, it'll be like personalized medicine, not only to that specific person, but that specific joint in that specific
Maybe.
person. How cool. We'll keep tuned to see how this plays out. I mean, ideally, I guess the idea with this is maybe to find some novel cytokines or targets for medications that could be even more effective than the stuff that we have going for
Correct.
today.
Right on.
Excellent. Let's switch a little bit to TRBV9 cells in axSpA, in axial spondyloarthritis. Tell us first, decipher what TRBV9 positive cells are and what role they have in axial spondyloarthritis.
Sure, John. So TRBV9 is a specific T cell receptor, and it's been known for a long time that CD8 T cells are really very important in the pathogenesis of axSpA. And for three different groups reported the expansion of CD8 cells in the peripheral blood of axSpA patients that had a preference for the TRBV9 receptor. So the
Hmm.
question that was addressed by Yang and others in a really critical paper in Nature in 2022 is, what are these TRBV9 cells reacting to? And so they hypothesized that HLA-B27 was probably very important at presenting the antigen that these receptors bind to. So they isolated these TRBV9 T cells from these patients and their CD8, of course, and then they exposed them to a yeast hybrid library in which you have all these different antigens that are presented in the context of HLA-B27, and you see which of these antigens turn on those TRBV9 cells to proliferate. And what they found was amazing, that they responded to 8 self antigens and several bacterial antigens. So this is really the first high level paper that comes back to this arthritogenic peptide hypothesis with real data. And so at this meeting, there was a study that was done by Michael Paley, who was on the first paper, and he wanted to see whether or not these TRBV9 cells might respond, other TRBV cells might respond to these bacterial self-antigen. It's called YEIH. YEIH is the name of the bacterial antigen. It stimulates these T cells in the context of HLB27. And he found that their TRBV3, 4, and 5 could also be turned on by this YEIH peptide. So showing that, once again, we're going to have individualized therapy to find out what is their TB9 cell reacting to. And the clinical element of this is there was a study published in Nature Medicine out of Russia where a physician who had very severe ankylosing spondylitis and had expansion of TRBV9 cells in the periphery was treated with a monoclonal antibody to TRBV9 and went into remission.
No kidding.
So there may be incredible therapeutic potential here. It's very specific, so toxicity would be low. You're removing a very small subset of T cells. And then at this ACR meeting as well, Max Koenig from Hopkins pointed out that TRBV9 cells are also important for celiac disease. And he was able to show using a bispecific T cell engager, one that binds to the T cell specifically, and you can actually have it binding to a cytotoxic T cell, and you can eliminate, or an antibody, and eliminate those TRBV9 cells. And he showed he was able to do that in vitro. So this is a whole new landscape that we're moving upon, which is different than CAR T because it's focused on the T cell, but using similar strategies.
That is super cool. And, this idea of these specific T cells that react to specific autoantigens or bacterial antigens in the setting of HLA-B27 sort of wraps everything, right? Like the role of HLA-B27 in these diseases, the role of microbes, which has always been thought to be important in these conditions. And now we see these specific cells that are expanded that target, those peptides. It's super cool.
They were
Super
also
great
present,
advancement.
these cells were expanded, John, in the uveitis fluid of HLA-B27 uveal patients and also in the synovial fluid. So this is just really more evidence for the importance of this mechanism.
Amazing. So in the future, we're going to see, I guess, like that trial in Russia, right? TRBV9, anti-TRBV9 antibodies maybe being successful in.
Or bite therapy, which may even be more effective.
Love it. Excellent. Moving on, one of your favorite topics is psoriatic arthritis. What do we know about sex differences in the presentation of psoriatic arthritis?
Yeah, perhaps there's a really great paper on these sex differences by Lee Eder out of Toronto from 2023. And what she found in a very comprehensive literature review was, and we've seen this in our trials and in our clinic as well, is that females tend to have more more swollen joints. They tend to have higher physician and patient global assessments at baseline. And compared to males who have higher PASI scores, higher CRP, but lower number of tender joints, swollen joints, and also they don't have the level of pain and globals that the females do. And so this has resulted in the observation in many trials where the female responses are significantly less than the male for all of the different biologic medications that we've looked at, except for the JAK inhibitors, which is interesting. So male-female responses are more equal to those in PSA. So what Leahy did was a proteomics analysis in male and female PSA patients. And what she was able to show was that there were 700 proteins in males that were increased expressed compared to only 31 in females. And the overlap was about 200. So when she looked at the pathways that were overexpressed in males, it had to do with immune response, netosis, phagocytosis. They had to do with cytokine and chemokine signaling. And so why it is that the males have so many more pathways engaged compared to the females is obviously the really important question. Does that help us explain why the females have more severe disease? I'm having trouble working through that, but I think that when we better understand those individual proteins and their pathways, that'll be the direction that will help us maybe to understand why we're having the differences in severity and disease response.
Fascinating. And sort of practically speaking, how should we think about treating men or women with PSA in our clinics? It sounds like women have more disease activity and respond less well to our traditional treatments. So should we be more aggressive, combination therapies, or
So we're
what's your approach?
We're grappling with that now, John. We're looking at all sorts of approaches, including combination therapies. We just finished a combination trial. It's yet to be released. We're looking at lifestyle interventions with a GP1 receptor agonist in
Oh,
patients who have obesity challenges. We're looking at dealing with anxiety and depression in a very aggressive way for patients that are experiencing higher in women than men. So we're looking at the biologics, the lifestyle, and also the comorbidities. And I think those might be the key to increasing the responses in females.
totally fascinating. So we'll have to get you back once you have results of all those studies and explain to us what we should be doing in our clinics. And I think the final article that you chose for this year in preview is about urinary biomarkers in lupus. And I've been hearing a lot about urinary biomarkers for a lot of diseases, lupus and Kawasaki disease and other things. Why are people so excited about these urinary biomarkers?
Well, lupus nephritis, as you know, John, has been a challenge throughout the years for all of us. To be able to adequately diagnose the disease requires a kidney biopsy, and oftentimes patients may not respond to therapy, and that requires a rebiopsy. And while our complement levels and anti double stranded DNA antibodies give us some partial view of what's going on in lupus nephritis, it's not nearly as good as pathology. On the other hand, if you could find a biomarker that would give you information that was similar to a renal biopsy, that would be a real advance because you could work through treating the patient more rapidly in the clinic and avoiding any side effects that might be encountered with renal biopsies. So, what this again came out of the AMP 1.0 lupus program and now is in the AMP 2.0. Anthony Fava at the Johns Hopkins University has really been working on these urinary biomarkers, and he's put together a panel of 10. Among these are interferon related genes and CD163. And he's been able to show that these urinary biomarkers correlate with the diffuse proliferative nephritis histology, particularly those that are grade 3 and grade 4, number one. And the second thing he's shown is that they also correlate with improvement in the histology with therapy.
Wow.
So it holds promise. We still need a lot more work, of course, that you could actually follow treatment responses with the urine. And that would be, it was better than complement, it was better than dsDNA, all the things we typically depend on. And so it wasn't so great for membranous nephritis or the earlier stages of proliferative, but certainly the more serious form. So again, it's early, but I'm just really excited by this possibility that, whenever we can get a great biomarker that's easy to get a hold of, we all jump at that because it's really great for patients and it's great for treating doctors.
That's amazing. So yeah, the idea that, you see your lupus patient and just routinely as part of the workup get these urinary biomarkers that help to predict, disease activity in the kidney more accurately would be really awesome. Especially as you mentioned, to monitor treatment response going forward, because time our nephrons, right? In glomerulonephritis. So if you could detect that the patient is not responding to therapy earlier, you'd be more willing to switch therapies and perhaps give them something that's a little bit more effective.
Agreed. And now we have all these CAR T bite therapies that we're moving into. So this is a whole new realm in terms of diagnosis and management that's incredibly exciting for the systemic autoimmune diseases in particular.
Great. And Chris, any other take home points from Convergence 2024 or what you're looking forward to this year's Convergence?
I think that, as I just mentioned, the CAR T cell and bite therapy and all these new approaches using NK cells and monocytes through FC binding, I'm really interested to see how that progresses over the next year because it's just incredibly exciting and novel. The other thing I want to point out, John, is I was asked to pick 5 abstracts I thought would really be important moving forward. That was really hard to do. There's a lot of really cool basic science going on out there that has potential therapeutic benefits. So I picked 5, but there's many others in there that I was unable to cover just because one has to be focused, right?
Yeah. Yeah, no worries. And these were really great because they sort of gave us a perspective about like all the things that are sort of a sampling of several different things within different diseases and different methods about, diagnosis, pathogenesis, and even treatment. So this was really helpful. And I hear you about CAR T cell. Just yesterday, one of my patients who'd had lupus since age of 9 asked me, "Doctor, are these therapies for me?" Right? Like, can I get cured before? Because she was thinking about pregnancy at some point. It's like, are these available for me? Fortunately, she's doing really well and she probably doesn't qualify for one of these clinical trials. But how exciting would it be that we'd have, cures for our patients with lupus and other
Well,
conditions going
especially the
forward?
younger patients where you can really have, if you can reset their immune system at a young age,
Yeah.
wow, think of all the suffering and disease you could avoid for these young people. I think that's where it's really potentially, maybe for everybody is, but I remember when I was a fellow at NYU in rheumatology, we had an 8-year-old that had an acute MI with lupus. I'll
Oh
never
my God.
forget it. And so you've seen cases like this. You're a pediatric rheumatologist, but these are the kinds of patients where we might really be able to make an incredible difference at an early stage. And that's just really exciting.
Yeah. Awesome. I couldn't say a bit better myself. Chris, thank you so much for your time. This has been really enlightening and hopefully we'll get you back to tell us updates from all the projects that you've been working on.
Sounds great, John. Really great to be with you.
Thank you. Well, there you go. An early look into the future of rheumatology. The research presented here is setting the stage for more precise, personalized, and effective treatments for a variety of rheumatic diseases. These advances have real potential to change how we diagnose, treat, and even prevent rheumatic diseases. This is certainly great news for rheumatologists and the patients we serve. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, continue creating the future of rheumatology. And of course, stay healthy.